and very lucky to welcome on our next guest for the Critical Care Clinical Pearls, Michelle Tsai. Now, Michelle is the current critical care PGY2 pharmacy resident at the University of Illinois, Chicago. Michelle, welcome. How are you doing today?
Good. Thank you so much for having me on.
The pleasure's all mine. I got to ask, we're recording this late October. I know when I was a resident, senioritis had hit me in a big way at this time. So let us know, are you already planning and looking forward to like a postgraduate trip? What's in the cards?
Yeah, definitely. That's what's getting me through the year right now. Hoping to go to Switzerland. That's kind of my dream vacation. So gonna get that in the works when I have some free time. But yeah.
Okay, when I think of Switzerland, because I've been there in one of the Euro trips, it's amazing. I think of three things. So which one are you going for? The cheese, the chocolate, or the views? Because that feels like the big three.
Yeah, 100% the views, the lake, the mountains. That's like my perfect combo.
And then once you do all of that, then you can unwind with the cheese and chocolate. So it's the perfect combo.
Yes.
One
Yes.
thing I will alert you of, it is more expensive than you think. So start saving up now, but it is awesome. Um,
Yeah. Yeah. I have heard that.
now don't let that deter you. That just means you're not going to have everyone coming over. No, it's awesome. And you're exactly right. This is the time where you need it's like the cartoon where Wile E. Coyote's running with the carrot in front, right? You gotta have a little something to motivate you through the dog days of residency. Now,
Yes. Yes.
one of my favorite ICU phrases to repeat: swell to be well, pee to be free. But can too much urine output ever be a problem? Michelle, take it away.
Yeah. So today we are going to talk about diabetes insipidus. The term diabetes insipidus, or DI, was first introduced to help differentiate between diabetes mellitus before we really knew DI's pathophysiology. But as we've learned more about DI, it's differentiated itself into central slash neurogenic DI versus nephrogenic DI, depending on the cause. There have been some documented cases, though, of confusion surrounding diabetes insipidus and mellitus that's led to inappropriate treatment in patients. So now there's more appropriate nomenclature being proposed. Instead of saying central or neurogenic DI, the term should now be arginine vasopressin deficiency or AVP deficiency. And instead of nephrogenic DI, the term should now be arginine vasopressin resistance or AVP resistance. So forgive me if I trip up on terminology throughout this talk because I also naturally want to say DI, but let's walk through the mechanism of each and kind of see why these terms make more sense. So arginine vasopressin, or AVP, is also known as antidiuretic hormone. It's synthesized in the hypothalamus and released from the posterior pituitary gland, and its release is regulated by osmotic pressure from fluid in the body. When osmotic pressure is low, below a set threshold, AVP is released to act on the kidneys, which will then induce translocation of aquaporin 2 channels that allow for water reabsorption, which will also help to concentrate osmolality of the urine. In arginine vasopressin deficiency, something is affecting the ability of the pituitary gland to release AVP. And without AVP, not as much water gets reabsorbed, allowing for large volumes to be excreted as urine, thus also making the urine very dilute. In arginine vasopressin resistance, AVP is appropriately being released by the pituitary gland, but the kidney is not responding appropriately to the presence of AVP, leading to the same effect as AVP resistance, but in a different mechanism. So the main concern that we have in patients with AVP resistance or deficiency is becoming hypernatremic, so serum sodium levels greater than 145. Looking at a hypernatremia decision tree, there are two things that will point us in the direction of AVP resistance or deficiency being the cause. First, we want to know how much urine is the patient producing? Are they putting out more or less than 40 milliliters per kilogram per day to classify them into high or low urine output? And a cutoff that's maybe more helpful in the ICU, since our patient's status is constantly changing, is greater than 300 milliliters per hour to classify high urine output. Since AVP resistant or deficient patients are not reabsorbing water, we would expect them to have high urine volume. Next, we want to see how dilute the urine is. In some cases, especially like in the emergency department, we might not have quantitative data for urine output, but we can measure how dilute the urine is to clue us in to whether or not there's AVP dysfunction. Urine osmolality less than 300 milliosmoles per liter or specific gravity less than 1.01 would be two different tests that could classify a patient with AVP resistance or deficiency. Urine osmolality or specific gravity will be low in patients with AVP resistance or deficiency because they have high urine output but less solute in their urine. Patients might also have high urine output, but urine concentration is normal because of other things such as use of an osmotic diuretic like mannitol. Mannitol will increase urine output, but will also be excreted and contribute to osmolality, making it normal, which is why tests like urine osmolality and specific gravity are important to help differentiate. There's not really much in terms of clinical testing that will help definitively tell you whether a patient has AVP resistance or deficiency. So patient history is commonly used to determine which makes the most sense. We'll see AVP deficiency more often in our neuro ICU patients because head traumas, cancers within the brain, strokes, or really any surgery involving the brain that can disrupt the pituitary gland and prevent it from releasing AVP can cause AVP deficiency. So patients will often even go to the neuro ICU just for monitoring of AVP deficiency after a surgery that could potentially affect the pituitary gland. Medications are what is normally to blame for AVP resistance, with lithium being the most documented medication to watch out for. It's thought to be caused because lithium inhibits the kidney's ability to induce aquaporins. But more related to medications that we see in the ICU, aminoglycosides, amphotericin B, and rifampin are other medications associated with AVP resistance, likely due to interstitial nephritis caused by these. And although there's no strong evidence, dexmedetomidine has also been frequently cited to be a causative agent for AVP resistance or deficiency. Other than looking at patient history or medications, another trick that can be used is giving a test dose of desmopressin or DDAVP at a low dose, 0.25 micrograms, often given IV in the ICU, and expecting to see a decrease in urine output and increase in urine osmolality if the cause is AVP resistance, which kind of brings us into treatment for AVP resistance and deficiency. So treatment of AVP deficiency versus resistance is different because of the difference in mechanism of action. In AVP deficiency, there is a deficiency in AVP, right? So we use medications to act like endogenous AVP. Synthetic vasopressin or brand name pitressin was originally the mainstay of treatment, but now DDAVP is a synthetic analog of vasopressin is now considered to be first choice because it has more antidiuretic activity but no vasopressor activity. DDAVP comes orally and as a nasal spray, but for the purposes of the ICU, I only included the IV dosing because this is probably what we're going to see more common. DAVP can be dosed from 0.5 up to 4 micrograms, most studies showing doses starting at 1 or 2 micrograms and can be given every 8 to 12 hours. Keeping in mind that our higher doses at 4 micrograms is what will have longer lasting effects up to 12 hours. We typically won't start a patient at 4 micrograms because we don't want to overcorrect sodium levels too quickly, but we can up-titrate dosing based off of response in urine output. For some patients, 4 micrograms of DDAVP may not be enough, so this is where you might see synthetic vasopressin being used, although pretty rare nowadays. Vasopressin can also be preferred in patients you also want to see vasopressor effect in, or if you want short-term control of antidiuresis, since it has a shorter half-life. But it can also be used adjunct to DDAVP in patients that need more antidiuresis. Most data and guidance on use of vasopressin in AVP deficiency is in potential organ donors. So using vasopressin starting at 0.01 units per minute up to 0.04 units per minute and titrating every 60 minutes. For both DDAVP and vasopressin, the aim is to titrate to decrease urine output by 1 to 2 milliliters per kilogram per hour. And then for AVP resistance, we can use diuretics such as hydrochlorothiazide, 25 milligrams once or twice daily, which can sound kind of odd at first because we're trying to reduce urine output using a diuretic. But there's a proposed paradoxic effect where hydrochlorothiazide upregulates aquaporin channels and distal sodium transporters to increase water reabsorption. And then a drug that I don't see too often is amiloride, a potassium-sparing diuretic, which you can relate to a more commonly known drug, triamterene. Amiloride is best studied in lithium-induced AVP resistance. Dosing is recommended 5 milligrams twice daily, but can be dosed up to 5 to 20 milligrams a day. And then carbamazepine is another medication we can use for AVP resistance, and it's a med that we normally name as a culprit for hyponatremia when it's not used for AVP resistance. Carbamazepine is proposed to have direct action on aquaporin channels to increase water reabsorption, and standard dosing is 200 to 800 milligrams a day for AVP resistance or deficiency. For patients with either AVP deficiency or resistance, fluid resuscitation is a key component since our patients are losing large volumes of water. We can help calculate a free water deficit to determine how much fluid to give back to them. And normally D5 or half normal saline can be used as IV fluids. If a patient can tolerate by mouth, we can give free water flushes. And in general, the overall goal is to decrease our serum sodium concentration by 0.5 milliequivalents per hour, or about 10 to 12 milliequivalents per day. And that's kind of AVP deficiency / resistance in a nutshell for you.
First things first, we got to give props for you being able to shuffle through AVP-D, AVP-R, crushed it. Got to give everyone flowers when they're due, and you certainly deserve those. Now, you did a really, really good job highlighting the considerations on starting up titrating DDAVP versus kind of vasopressin. But my kind of question is, how do we kind of titrate down or even stop? Do we have any specific labs or objective markers? You mentioned we don't have them to help with our diagnosis, but do we have any of those things that we can help with trying to, because the goal is eventually to try to back off some of these things?
Mm-hmm. Yeah, definitely. It's difficult in the ICU, and we don't have a ton of literature to tell us when to stop or when to titrate off. Hopefully, in these patients, we're trying to dose DDAVP as needed, so that would kind of negate the need to titrate off. But for patients that are showing a consistent pattern for need of DDAVP, we can definitely see it scheduled. So especially for controlling our patient's fluid intake, the main way to tell if we should titrate or trial off of DDAVP is to see if our patients start to become hyponatremic, because then we'd be seeing the endogenous AVP working on top of DDAVP. You maybe could decide to trial off of DDAVP if urine output starts to decrease, but it'd be important to keep in mind what fluids the patient is getting in to make sure less fluid intake is not the culprit of less urine output. And another thing is that patients can stop DDAVP at once. They don't always have to be titrated off. It is a good idea always to continue to closely monitor urine output, sodium levels, specific gravity, or urine osmolality for the same parameters we talked about previously to diagnose AVP deficiency or resistance, because we can always give doses as needed.
Yeah, you highlighted that's what makes this kind of the care of these patients so complicated because there's so much kind of subjectiveness, right? You're looking at, okay, we dosed this, let's see what their urine output is in 3 to 4 hours, and we'll kind of decide. So it's I thought you did a really good job of not only highlighting the nuances, but letting us know it's not tons, but the things that we do know, you definitely let us in on. So that was awesome. Michelle, very thankful for this critical care clinical pearl. And I will say, I got to stop referring to it as DI. This is the first time that I had a clinical pearl mislabeled. So again, kudos again to Michelle. Appreciate you.
Yeah, thank you so much. It's definitely difficult for me also transitioning that terminology.